Hello. Right, my dear friends. So we are back. Let me just check if everything is fine. Abeda from Grodno, beta. If the stone is present in the pelvic junction, the symptoms will be of hydronephrosis. There will be swelling and pain in the lumbar region. Its symptom will be like kidney stone symptoms or ureteric stone symptoms. At the pelvic-ureteric junction, it will be like ureteric stone. If stone size is 12 millimeter, go for ESWL beta. There's a question where chronic alcoholic female with chronic liver disease with sudden onset hematomasis most likely cause. Answer would be bleeding varices, because this is a clear-cut case of portal hypertension. This was the question which was asked on 4th of June 2022. And please do mention your details, beta. Since there are just few queries here, so I thought Lance and Rocky Davis is not the same thing, beta. Rocky Davis is a muscle cutting and Lance is a muscle splitting incision. One more doubt: pregnant woman who is having symptoms of private and ultra do not visualize anything. Then our next step will be CT. No, pregnancy we cannot do a CT scan, beta. In pregnancy we cannot do a CCT. Better to go for appendicectomy. Please request Hariom Bhaiya beta. Vijay from Bogomolets. Siva from Bogomolets. Most common sites. Basically lower esophagus, Meckel's and stoma. Basically in Meckel's we know there is a gastric epithelium, so peptic ulcer can occur there. Stoma of gastrojejunostomy, again the gastric epithelium is there, and lower esophagus, whenever there is a metaplasia in the lower esophagus, then we can find these peptic ulcers there in the lower esophagus. Last 5 digits 43506. Please do mention your details. In TURP, there will definitely be a damage to urethra. We just leave a Foley's catheter over which the new urothelium grows. Please mention your details, beta. 374364. Barium, if there is GI perforation, definitely to leak out of the GI tract and will cause injury to the surrounding organs. A single patient suffers from early and late dumping syndrome. Please do mention your name and university, beta. I think it's better I could reply to the queries later on, or I think in Mallory Weiss, beta, there is a binge drinking history. How do we differentiate? This is a good question, what I feel. Please do mention your name and university for sure. The question is, the patient is coming to you with hematomasis. Now, how in the questions on 17th of December, you will be differentiating whether this is Mallory Weiss or whether this is esophageal varices. So, beta, we should know that Mallory Weiss is something which is a sudden onset, acute onset. Somebody takes 4 bottle vodka suddenly. Then this is an acute insult. There is forceful vomiting, which causes tearing of the gastric mucosa. But esophageal varices is something they will take years to develop. So portal hypertension is a chronic disease. So if the story is related to some chronic insult, like chronic liver disease or something, and then the patient is having hematomasis, then yes, you will go with the portal hypertension esophageal varices. Right, beta. So I think no more queries as such. Great. Perfect, beta. So now let us straight on start where we left. So we were talking about the hernias actually, and in the hernias, basically, we discussed what is the inguinal hernia, what is the direct, what is the indirect inguinal hernia. We talked about the femoral hernia a bit, that if the herniation occurs through the femoral canal, then it's a femoral hernia. Now, beta, before we proceed, I think let me just give you a glimpse of the different classifications, what we do for the hernias. And in these different classifications, basically, there is one European Hernia Society classification, which says that we can use certain letters to describe the different hernias, like P and R. P is for primary, R is for recurrent. Primary means first time the hernia has occurred. Recurrent means again and again the hernia is occurring. P primary पहली बार हुआ है, R recurrent बार बार होता है. We can use letters like L, M, F. L lateral, M medial, F femoral. So in the inguinal hernias, beta, can you please tell me which is a lateral hernia? Indirect or direct? Lateral is indirect and medial is direct. So we can just use the letters LMF. We can use some numbers 1, 2, 3. Now we know that herniation is occurring through some defect, like deep inguinal ring is the source for indirect inguinal hernias. So when you are examining these patients, if you are able to put one finger into the deep inguinal ring, that is number 1. If you are able to put 2 fingers, number 2, 3 fingers, number 3, so on. And 1 finger breadth, since it is the European Hernia Society classification. So if you look at the European fingers are a little broad. So we take this 1 finger as 1.5 centimeter defect. So we can use these letters. Suppose somebody uses the letter, or 17th of December you get a question ki bhaiya there is PL2. Now P means primary, L means indirect inguinal, and 2 means 2 fingers. That means 3 centimeter defect. So that is how we can use this European Hernia Society. Another classification is a NIHAS classification, beta. Now this NIHAS is something which your examiners are fond of. And NIHAS says 4 categories of hernia. Out of this, first, second, 1, 2, indirect. 3 is further divided into 3, A, B, C. 3A, direct. 3B, both direct as well as indirect on the same side. 3C, femoral. And 4 is for recurrent. So let's learn this beta, NIHAS classification, right? 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. Now you have to speak out from your vocal cords, beta, right? 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. Let's do it again. 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. Now 1, 2, 3A, 3B, 3C, 4. Very good. Wonderful. 1, 2, 3A, 3B, 3C, 4. Very good. Once again. 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. So that is how we have to remember this NIHAS classification. And there have been the questions which have been asked here. They have asked direct inguinal hernia belongs to which category of NIHAS? So the answer was 3A. They've asked recurrent hernias belong to which category? The answer was 4. Right. Then there is another classification, which is a clinical classification, depending on the clinical presentation of the patient. For example, occult hernias. Occult means hidden. So when the patient comes to you and he tells you, doctor, I feel some discomfort in my inguinal region here. And when you clinically examine, you are not able to find any hernia. So we just call them as occult hernias. Reducible hernias. Suppose the herniation is taking place. For example, if I say that this is the peritoneum, right? Suppose I say this is the peritoneum, which is lying in the abdomen, right? Now, when the intra-abdominal pressure is high, like in me, obesity, so this high intra-abdominal pressure may try to force this peritoneum to move out through the deep inguinal ring. So there is a possibility that through my deep inguinal ring, there is a protrusion of the peritoneum. Now, when this peritoneum is protruding in the inguinal canal, right, sometimes what will happen, the contents inside the peritoneal cavity, like the intestines, they may also be going through this hernia. For example, if suppose I say that this is the peritoneum, what you are seeing, right? I'm showing it from inside. This is the front view. Now, if I say that intestine also start moving through this, so the intestine also starts moving into this. And now what can happen? This herniation is protruding like this. The intestines are also going into this, right? So there is a possibility that these intestines along with the peritoneum is going into my scrotum. And now when you are examining, if you just try to reduce these contents from the scrotum, you would be able to move these contents. These are the contents, beta, right? Suppose this is the peritoneum and the intestine which are lying in my scrotum. Now, when we examine, you are able to easily move these contents back and they'll go back into my peritoneal cavity. So this is the commonest type of presentation what you are going to get in clinical practice. These hernias are called as reducible hernias. I repeat this in Hindi, beta. Hernias majority जो आपको मिलने वाले हैं वो reducible टाइप के हैं. होता क्या है हर्निया में, जब भी अंदर का प्रेशर ज़्यादा है तो वो जो अंदर की पेरिटोनियम है पहले तो उस पर प्रेशर डालेगा, तो पेरिटोनियम बेचारी जो है डीप इंग्वाइनल रिंग से मान लो इंग्वाइनल कैनाल में आना शुरू हो गई. कहीं से भी आ सकती है, डीप से भी आ सकती है, ईसलवेक्स ट्रायंगल से भी आ सकती है, फीमोरल से भी आ सकती है, लेकिन कॉमन अपना इनडायरेक्ट है. तो अपन डीप इंग्वाइनल रिंग का एग्जाम्पल ले रहे हैं. मान लो पेरिटोनियम भाई साहब जो हैं ये डीप इंग्वाइनल रिंग से इंग्वाइनल कैनाल में जा रही हैं. अब इंट्रा एब्डोमिनल प्रेशर अगर बहुत ज़्यादा है तो ये धक्का पड़ता रहेगा और धीरे धीरे पेरिटोनियम जो है ये नीचे स्क्रोटम तक भी जा सकते हैं. कभी कभी जो पेरिटोनियल कैविटी के अंदर का मसाला है, चाहे वो ओमेंटम हो चाहे वो इंटेस्टाइन हो, वो भी इस रास्ते से पेरिटोनियम के अंदर नीचे तक जा सकते हैं. जब पेशेंट अपने पास आता है तो पेशेंट को हो सकता है कोई स्क्रोटम में स्वेलिंग हो या इंग्वाइनल रीजन में कोई स्वेलिंग हो, और जब आप इसको एग्जामिन करते हैं तो बड़ी आसानी से आप जो भी ये सामान नीचे उतरा हुआ है, इस सामान को अगर आप थोड़ा सा भी धक्का देंगे तो ये सामान वापस से पेट के अंदर चला जाता है. मेजॉरिटी हर्नियाज जो होते हैं वो इस तरह के होते हैं. इसको अपन बोलते हैं रिड्यूसिबल. अपन इसको रिड्यूस कर सकते हैं, राइट? ओके. कभी कभी क्या होता है, समटाइम्स व्हाट हैपन्स इफ द हर्निया is suppose present there for a long period of time, and this peritoneum keeps on coming into the scrotum, going back, going back. So maybe over a period of time, maybe over years, 5 years, 10 years, what can happen if this is untreated? Then this peritoneum can form relations with the scrotal fascia inside, and if the peritoneum gets attached to the scrotal fascia, then when you examine these patients, because of the attachment of the peritoneum with the scrotal fascia, you will not be able to reduce that. So this is what we call as irreducible. I repeat this in Hindi, beta. अगर मान लीजिए बरसों से ये आना जाना लगा हुआ है, तो अगर हम किसी के घर बरसों से आ जा रहे हैं तो धीरे धीरे उनसे रिश्ते बनना चालू हो जाते हैं, और कभी कभी रिश्ते इतने मजबूत हो जाते हैं कि फिर हमें वहाँ से आने का मन नहीं करता. तो ऐसा ही कुछ यहाँ हो सकता है कि भैया पेरिटोनियम जो है वो स्क्रोटम में गई, उसका स्क्रोटल फेशिया के साथ कुछ रिश्ता बन गया, और फिर पेरिटोनियम ने कहा जी आप कहीं नहीं जा रहे, अब तो हम यहीं रहेंगे. तो ऐसे केस में जब पेरिटोनियम के रिश्ते बन गए स्क्रोटल फेशिया के साथ, तो फिर हम इस पेरिटोनियम को धक्का देके वापस नहीं भेज पाएंगे, इसको अपन बोलते हैं इररिड्यूसिबल। अनदर स्टोरी, obstructed. Now we know that suppose we are talking about indirect inguinal hernias, the herniation is occurring through the deep inguinal ring. This is a ring, right? So we are just talking about the ring. Okay. Now what can happen? Sometimes when the herniation is occurring, if the ring is tight, then whatever is coming in the inguinal canal, you are not able to put it back because of the tight ring. If the ring is tight through which the herniation is occurring, and because of the tight ring you are not put the contents back, this is what we call as obstructed. And sometimes this ring becomes so tight that it starts putting pressure on the blood supply of the organs inside, and then the chances of ischemia and strangulation to these organs will be high. So this is called as incarcerated hernia. Incarcerated hernia. In Hindi, अगर जिस रिंग से सामान बाहर आ रहा है, अगर वो रिंग ज़्यादा टाइट है, तो उस टाइट रिंग की वजह से आप जो सामान बाहर आ गया है उसको वापस धक्का नहीं दे पा रहे हैं। इसको अपन ने बोल दिया कि भैया ट्रैफिक जाम लग गया है, ऑब्स्ट्रक्टेड हो गया है। अगर ये रिंग बहुत ज़्यादा टाइट हो गई जिससे कि जो ब्लड सप्लाई जा रही है इसकी, उस पर भी दबाव पड़ गया, तो इसकी सप्लाई ख़त्म हो जाएगी, ये धीरे धीरे खत्म हो जाएगा, इस्चीमिया होने लगा, स्ट्रैंगुलेशन होने लगा, गैंग्रीन हो सकता है, ये इमरजेंसी सिचुएशन बन गई, इसको अपन इनकार्सरेटेड बोलते हैं। तो बेटा क्लिनिकल क्लासिफिकेशन में अगर अपन देखें, इन क्लिनिकल क्लासिफिकेशन देयर आर 5 टाइप्स: ऑकल्ट, रिड्यूसिबल, इररिड्यूसिबल, ऑब्स्ट्रक्टेड एंड इनकार्सरेटेड, राइट। चलिए, another classification is based on the contents, what is coming into this hernia. If the omentum is coming into this hernia, we call it as omentocele or epiplocele. And omentum, if it has come into the scrotum and you examine, it gives a doughy feel. So omentum, dough means that जो गुथा हुआ आटा होता है ना, जब अपन आटा गूंथते हैं तो वो जैसे डो होता है ना, जो उसको अपन जो गुथा हुआ आटा है उसको डो बोलते हैं। तो दैट डोई फील इन द इंग्वाइनल हर्नियाज, दैट इज बिकॉज ऑफ प्रेजेंस ऑफ ओमेंटम। इस तरह से डिपेंडिंग ऑन व्हाट इज द कंटेंट विच इज कमिंग डाउन, वी कैन क्लासिफाई दीज हर्नियाज अकॉर्डिंगली, राइट। ओके, now let's take a look. In the European Hernia Society classification, P primary, R recurrent, LMF, L lateral that is indirect, M medial that is direct, and F femoral. 1, 2, 3, 1 finger, 2 finger, 1 finger 1.5 centimeter, 2 finger 3 centimeter. So if on 17th of December you get this PL2, then you know this is a primary indirect inguinal hernia where the defect size is approximately 3 centimeters. Then beta Nihas classification. According to Nihas, 1, 2 indirect. This is small. This is large. 3A direct. 3B both. Now both means what? Indirect as well as direct inguinal hernia. 3C femoral, and 4 recurrent. So that is how we can classify this Nihas. 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. Right बेटा जी? चलिए आगे चलते हैं. Clinical classification. In this clinical classification, we can classify these hernias into occult, reducible, irreducible, obstructed, incarcerated. Occult, which is not visible, reducible, which is visible. Positive cuff impulse is there. That means when you ask the patient to cuff, the hernia comes out and you can put this back. Okay. So simple reducible. Irreducible, which cannot be reduced back. This may be due to adhesions. Right. Obstructed is due to narrow neck of the sac, and incarcerated is gangrenous. This is the dire emergency type of situation. Then beta, another classification is on the basis of content. What is there coming in the hernia? So herein, if suppose omentum comes, that is omentocele, this gives a, this omentocele or epiplocele is when omentum is present in the hernial sac. This gives a doughy feel. Doughy feel. Enterocele beta. Entero we all know. Entero means intestine. So when intestine is coming into the hernial sac, we call it as enterocele. Litters hernia beta. In pediatric surgery, we talked about Meckel's diverticulum. If Meckel's diverticulum is present in the hernial sac, that is Litters. Amiens. If suppose appendix comes in the hernial sac, that is amiens. Richters. Richters is when circumference of the intestine, is coming into the hernial sac. Like herein, what we are seeing, this is the intestine suppose, and now what has happened here is that this part of the intestine has gone into the hernial sac. So circumference of the intestine has gone into the hernial sac. This is what we can say the Richter's type of hernia. This is a Richter's hernia when circumference of the intestine has gone into the hernial sac. Then there is a Madel's hernia beta. Madel's hernia, MW, when there is W loop of bowel in the hernia. W loop of bowel present in the hernia. Now for example, if suppose this is the intestine normally, and now what has happened is the intestine has gone somewhat like this, and there is another loop coming here. So this is what is a W loop of bowel. If this type of story is present in the hernia, then we call it as Madel's. Sliding hernia beta, if you remember the sliding hiatus hernia, where because of gastroesophageal reflux, how the reflux was forcing the gastroesophageal junction to move up into the thorax. So sometimes we can find the sliding type of story in the inguinal hernias also. When the peritoneum is going into the inguinal canal, then maybe along with this some organ is also going, not as a content but as a part of the wall of the hernial sac. That is sliding. Like left side it is more common, and on the left side the mobile part of the intestine is the sigmoid colon. So most common sliding hernia what we see is where sigmoid colon forms one wall of the hernial sac. And second, most commonly it is on the right side when cecum can go into the inguinal hernia, forming one wall of the hernial sac. Pantaloon or saddle, this is a double inguinal hernia. And Cooper's is a double femoral hernia. Pantaloon or saddle, this is a double inguinal hernia, and Cooper's is a double femoral hernia. So these are the various names which can be used depending on the content. Now what we actually do in the management of these hernias, for this, in our clinical approach, first we examine the patient in the supine position, And majority of the hernias, they are reducible. So if you're seeing a hernia coming through the inguinal canal into the scrotum, you can easily reduce this content back. And then what you can do is you can ask the patient to stand up, and suppose the contents have been reduced by you already. Now when the patient stands up, sometimes the hernia comes out automatically, but sometimes the hernia is not coming out automatically. Then you ask the patient, "Muh udhar kariye." The patient turns the face on the other side, and now you ask him to cough. Khansi kariye. Now when the patient coughs, the intra-abdominal pressure increases, and this may force the hernia to come out. And this is what we call as positive cough impulse. So we can see the hernia coming out when the patient is coughing, right? So that is how we can examine these hernias. Now, whenever there is some doubt that whether it is an indirect hernia or a direct hernia or it is a femoral hernia, if by chance there is any doubt, then we can take the help of a 3-finger test. Very simple test, beta. What we can do here is, we know that indirect inguinal hernia will come out through the deep inguinal ring. Direct inguinal hernia will come out through the Hesselbeck's triangle, and femoral hernia comes out through the femoral canal. So just imagine, beta, patient is presenting with a swelling in the inguinal region or inguinoscrotal region, and you are not able to make out what is this hernia. Now, in these cases, you ask the patient to lie on the examination couch, reduce the hernia back inside the abdomen, and then use your 3 fingers to block the 3 sides. What you can do here is, you can just put your 1 finger here, another finger here, another finger here. For example, suppose these are the 3 sides, and now I'm trying to block the 3 openings with my 3 fingers, right? So I can put a finger on the femoral canal, I can put a finger on the Hesselbeck's triangle, I can put a finger on the deep inguinal ring, right? So that is how I'm going to block all the 3 sides. Now I keep these 3 openings blocked. I ask the patient to stand up now. The patient is standing. I ask the patient to cough. Nothing will come out if I block these openings nicely. Now what I'll do is, to identify from where the hernia is coming out, I will just release fingers one by one and ask the patient to cough. If the herniation comes out through this opening, that means this is a indirect inguinal hernia. And so, likewise, that is how this 3-finger test or Siemens test can be done to differentiate the indirect, direct, and the femoral hernias. Right, beta. In the treatment of all the hernias, there is one simple story. जो भी अपना घर छोड़ के चला गया है, उसका कान पकड़ा जाए, उसको वापस घर के अंदर डाला जाए और ऐसा ताला लगाया जाए कि दोबारा बाहर जाने की गलती ना करे. The basic concept in the treatment of all the hernias is, whatever has gone out of his house, you have to just hold on to his ears, put it back, and then create a barrier so that it never goes out again. Here, in the treatment of these inguinal hernias, what we can do is we can simply open the inguinal canal. For example, herein, what we can do is, this was the inguinal canal. Suppose I say that there was a hernia which was coming here. From the deep inguinal ring, there was a herniation and this was going into the scrotum. So what I have to do first is, I have to cut the skin, subcutaneous tissue, external oblique aponeurosis. I'll enter into the inguinal canal. Then I know there is a spermatic cord here and there is a hernial sac. So first what I have to do is, I have to separate the hernial sac from the spermatic cord. So I'll just try to separate the hernial sac from the spermatic cord, and then I have to put this back. So, for example, if this was the hernial sac, now I have to put this back, right? So I'll put this back through the deep inguinal ring, okay? and this goes inside. Once it goes inside, then I have to create a barrier so that it does not come out again. For that barrier beta, we can use something like this. This is a Prolene mesh, what you're seeing on the screen. This barrier can be just put over the transversalis fascia. This is a mesh. Another picture. This is what we can use. Right. So you are just going to put these Prolene meshes. You will just put this Prolene mesh right from here all over the place. And this Prolene mesh will not allow any herniation to occur. This is called as tension-free hernioplasty or a Lichtenstein operation. And once you have put the mesh, then you have to just close the external oblique aponeurosis and close the skin. Simple operation. जो बाहर आया था उसको अंदर धक्का दे दिया गया और फिर प्रोलीन मेश जाली बिछा दी गई जो कि अंदर के सामान को बाहर नहीं आने देगी. Right? Earlier what we were doing was we were doing lot of different type of operations. When we did not have this mesh, what we used to do after putting the hernia back, then now we had to apply a barrier. But if there was no artificial barrier, then we used to try to put the sutures from the conjoint tendon to the inguinal ligament. Inguinal ligament is actually fixed to the bone all over. So when you're trying to put the sutures of conjoint tendon with the inguinal ligament all over the place just to put an extra strength or a barrier here, then these sutures were under a lot of tension, and many a time these sutures they used to break and the hernia recurred. That was full of tension. Or surgery mein we know there should not be any kind of tension, neither while doing surgery nor while reading surgery, है ना. तो जब पहले जो ऑपरेशन करते थे बेटा उसमें क्या करते थे अपन, हर्निया को वापस से धक्का देने के बाद इस इलाके को स्ट्रॉन्ग बनाने के लिए अगर हमारे पास बाजार से लाने के लिए कुछ नहीं है तो हम यहीं पे जो कंजॉइंट टेंडन होता था उसको लेके इंग्वाइनल लिगामेंट के साथ सूचर कर देते थे. अब इंग्वाइनल लिगामेंट जो है बेटा वो तो हड्डी के साथ फिक्स्ड है. जैसे अपन ने जीआईटी में ड्यूडनम देखा था ना, पैनक्रियास के साथ फ्यूज था, तो अपन ड्यूडनम को मोबिलाइज नहीं कर पा रहे थे, इसलिए सब जगह उठा उठा के शरीफ आदमी ले जा रहे थे जजनम को, है ना. तो अब यहाँ पे इंग्वाइनल लिगामेंट जो है हड्डी के साथ फ्यूज्ड है, तो हम इसको इससे नहीं जोड़ पाएंगे. जोड़ने की पहले यही किया करते थे, लेकिन जब जोड़ते थे इस तरह से तो टेंशन आती थी, टाँके टूट जाते थे और फिर हर्निया दोबारा हो जाता था. So nowadays what we are doing is a tension-free hernioplasty, right? That is a mesh hernioplasty, and usually if we take a look at the quality of these meshes, then generally we say that this mesh what you are seeing, this should have thin thread, पतले धागे होने चाहिए, and there should be large pores between the threads. Why these pores are there? Because this mesh will stay at that place by the growth of granulation tissue through the pores in the mesh. So if there are large pores, good amount of granulation tissue will grow and that will help in fixing the mesh. There is no need to fix the mesh with sutures or something like that. Right. So in the treatment, our aim is to reduce the contents and apply a barrier. We are doing a hernioplasty. This is a open surgery. This is a tension-free Prolene mesh. Hernioplasty. This is called as Lichtenstein operation. Earlier, the operations which we were doing, Bassani's, Shoulders, Stopas, these were the operations which we were doing earlier. But now the standard dictum is we just follow the standard guidelines, just use a Prolene mesh. The mesh can be made of different materials nowadays, like here polypropylene, polygalactin. The mesh should have thin thread, पतले धागे होने चाहिए, large pores, बड़े छेद होने चाहिए. We can even do these surgeries laparoscopically, and the laparoscopic approaches are TEP and TAPP, totally extraperitoneal and transabdominal preperitoneal repair. Nerves which can be injured in open hernia surgery, most commonly it is the ilioinguinal nerve. Most commonly it is the ilioinguinal nerve. And you know what? Why this ilioinguinal nerve is injured most often? Just imagine that suppose this was the inguinal canal, right? Now in this inguinal canal, when you cut the skin, subcutaneous tissue, then there is external oblique aponeurosis. Just imagine that this what you are seeing, beta, this is the external oblique aponeurosis, right? As soon as you will cut this external oblique aponeurosis, you will actually enter into the inguinal canal. Spermatic cord gir gayi. Just a minute. Right. So, basically what happens here is the ilioinguinal nerve is lying very close to this external oblique aponeurosis. If you carefully take a look, beta, can you see this is the ilioinguinal nerve which is lying very close to the external oblique aponeurosis. Now when you are making a cut, there is a risk that you might cut this ilioinguinal nerve, right? So that is why what we do actually is we just make a small cut in the external oblique and then we put our finger inside and we just do a finger dissection inside and try to separate this ilioinguinal nerve. If we are able to separate this ilioinguinal nerve, then yes, the chances of injury to this will not be there. Okay. Other nerves which can be injured include iliohypogastric and genital branch of genitofemoral nerve. Now, treatment of choice for congenital hernia and hydrocele is slightly different. ध्यान रखिएगा बेटा, just remember one thing. In small babies, we do not use mesh because these meshes are non-absorbable. They create a foreign body reaction and because of that, adhesions develop. So if we are using a mesh in a small baby and if adhesions develop between the tissues there, then the growth of that particular area will be hampered. So small babies, we don't use these meshes. They are not used in the growing age. Now, first of all, we should know what is the concept of congenital hernia or hydrocele. Suppose, beta, this is the anterior superior iliac spine. This is the pubic tubercle. This is the pubic symphysis. And here is the scrotum. Right. Suppose I say that this is the inguinal canal here. We know that the testes follow a definite path of descent through the inguinal canal. And the testes are actually falling down somewhat like this just before birth into the scrotum. Right? So this is the normal track what we know about. Fine? The testes generally descend down to the bottom of the scrotum before birth. Now what can happen here? What we have seen that during intrauterine life, we have seen that it is not only the testis or the story like this, but actually the peritoneum. Suppose I say that this is the peritoneum. In all of you, beta, right now, in a normal individual, the peritoneum is not going into the inguinal canal. But during intrauterine life, what used to happen was this peritoneum used to go into the inguinal canal like this. The peritoneum used to be like this during intrauterine life. Okay. That means whatever was there inside the peritoneal cavity, whether it was some fluid or maybe omentum or anything, there were chances that this story was coming into the scrotum and it was going back also. I repeat, beta, during intrauterine life in all of us, the intraperitoneal contents, whatever it is, whether it is fluid, omentum, intestine, all these contents were actually going through this inguinal canal into the scrotum, and they were coming back also, right? So this was actually a normal communication during intrauterine life. This communication is called as processus vaginalis. But what actually happens before birth? This ana jana disappears. This coming and going story disappear, so that after birth the story becomes like this. And after birth, whatever is there inside the peritoneal cavity, whether it is fluid or maybe omentum or anything, that does not go into the inguinal canal. This is the normal story. But sometimes, beta, what can happen? If suppose this communication or this peritoneum, which used to get obliterated before birth, does not get obliterated, and this story remains patent like this even after birth. So now we can very well see what is going to happen here. In this particular case, whatever is there inside the peritoneal cavity, that can easily travel through this communication and can come into the scrotum. Now, beta, in the peritoneal cavity, there is a normal fluid also. So, if suppose fluid from the peritoneal cavity that comes through this processus vaginalis and starts getting collected inside the scrotum, this will cause enlargement of the scrotum, and this fluid collection around the testis is called as hydrocele. Since this is a congenital story present right from birth, because this communication has not obliterated, these hydroceles are called as congenital hydroceles. Apart from this, beta, if suppose it is not the fluid, but suppose some contents, say suppose the omentum is coming through this connection, suppose, or maybe the intestine is coming through this connection even after birth, then this is called as a hernia, and this is what is a congenital hernia. So conceptually what we know, whether it is a congenital hernia or a congenital hydrocele, the story is persistence of the processus vaginalis. अगर ये अपनी processus vaginalis obliterate नहीं हुई, जन्म के बाद भी ऐसी रह गई, तो जो पेरिटोनियल कैविटी के अंदर का सामान है वो भी तो इस रास्ते से आएगा, और अगर पानी आएगा तो यहाँ पे पानी इकट्ठा हो जाएगा, उसको हाइड्रोसील बोलेंगे. अगर मान लो पानी नहीं, ओमेंटम आता है या इंटेस्टाइन आता है, तो उसे हर्निया बोलेंगे. अब चूंकि ये कहानी तो बर्थ से है, जिसमें प्रोसेसस वजाइनलिस बंद ही नहीं हुई, तो इसलिए इसको अपन कंजेनाइटल बोल देते हैं. So that is the story of congenital hernia and congenital hydrocele. Right, beta G? We have seen over a period of time, the studies have shown that even if the baby is born with a congenital hydrocele or a congenital hernia, usually what happens? They regress spontaneously. Because ये आना जाना तो लगा ही हुआ है. They are coming and they are also going back. And over a period of time, maybe up to 2 to 3 years of age, this regresses completely, and by 2 to 3 years of age, the story disappears. That means generally surgeons are not required to intervene up to 3 years of age. But if this connection persists even after 3 years of age, then we have to do something. अभी something में क्या करना है? We have to simply reduce the contents and close the connection. So what we do is, we are going to make a cut in the inguinal canal, open the inguinal canal, identify this connection, put the story back through the deep inguinal ring into the peritoneal cavity, just to close the inguinal canal. That means we are just opening, nothing, no plasty, no mesh, nothing is being done. Right? This is called as herniotomy. क्या बोलते बेटा इसको? What do we call this? Herniotomy. So treatment of choice for congenital hernia or congenital hydrocele is herniatomy. Herniatomy. And generally, this operation is done after 3 years of age. After 3 years of age. This is a hot MCQ beta. Congenital hernia, congenital hydrocele. The examiner wants to know the concept. Do you understand what is a congenital hernia? What is a congenital hydrocele? Yes, it is so simple. It is just the persistence of the processus vaginalis. That is why the peritoneal story might be coming down through this processus vaginalis into the scrotum. So we have to just open the inguinal canal, put the story back into the peritoneal cavity. That's it. This is herniatomy. Right, beta. Now some points about other hernias like femoral hernias. These are 4 times more common in females. This is the most common hernia to undergo strangulation. Femoral hernias are more commonly seen in elderly females, especially low-weight females. When the tissues have become weaker and weaker, then the chances of herniation through the femoral canal are high. In the anatomy classes, beta, we'll be reading something that suppose this is the thigh region, and herein I say that this is the groin crease area. This is the groin crease. Now what happens? 2 centimeters below the mid-inguinal point, we feel the femoral artery. Actually speaking, beta, herein there is a femoral sheath. There is a femoral sheath here. And in this femoral sheath, we can divide this into 3 compartments. The lateral compartment, then the intermediate compartment, and then the medial most compartment. Right? The lateral most compartment belongs to the artery. So here lies the femoral artery. The intermediate compartment belongs to the vein. So here lies the femoral vein. And the medial most compartment is empty. So this is what we call as the femoral canal. And sometimes herniation can occur through this femoral canal. That is what is a femoral hernia. In the treatment, we have got different approaches. Concept is same. We have to reduce the contents and put a barrier. The different names of the operation, what we are using: Lothison, Lockwood, and McEvedy. Lothison, Lockwood, and McEvedy. These are the operations we can do for femoral hernias. Umbilical hernias. Now here I would like to draw your attention, beta. If you just take a look at this umbilicus of the small baby, you know how cute the baby is, right? Normally, beta, what happens when during intrauterine life, the story is actually like this, and gradually what happens? The tissues beneath the umbilicus, from this side, from that side, they are coming and they are trying to fuse. So generally the tissues fuse normally and there is no defect here, and the baby is not having any hernia through the umbilicus. This is the normal story. But sometimes, beta, when the baby is born, even by that time, the tissues have not met with each other from both sides, and some weakness may persist beneath the skin area here. And if there is a weakness beneath the skin in the umbilical area, then we can understand the inside story can come out through the umbilicus. So that is the pathogenesis of umbilical hernias. You might have seen a lot of small babies when you're moving in the slum areas. Beta, there was a movie Slumdog Millionaire, है ना? उसमें भी हमने देखा था कैसे वो छोटे छोटे बच्चे बेचारे बिना कपड़ों के घूमते रहते हैं, नाक बहती रहती है और वो या तो रोते रहते हैं या हंसते रहते हैं. जब भी वो रोते हैं ज़ोर ज़ोर से तो उनकी अम्बलाइकस कभी कभी जिनमें अम्बलाइकल हर्निया हो उनकी अम्बलाइकस ऐसे अंदर बार होती हुई दिखाई देती है, right? So I'm just trying to give you an example, a situation, a scenario that you might have seen those small babies, especially in the slum area. If suppose they're not wearing anything, and suppose some boy is having that umbilical hernia, and his nose would be coming out, he would be crying or maybe laughing. Then you see that with every inspiration, expiration, if he's doing movements with pressure, then you might be seeing the bulge of the umbilicus coming out and then going in. Right? So this is what is the umbilical hernia story. Here also, we have seen that this story should be considered normal up to 2 years of age, because by 2 years, generally this story settles down. Generally, the tissues, they come close to each other, they unite, and then the area becomes strong beneath the umbilicus, and now after 2 years, there is no herniation spontaneously by God's grace. Sometimes if there is any grandmother at home, दादी नानी अगर घर पे होती हैं, तो they might keep some 2 rupee coin here and they can put a tape here so that when the baby laughs, the umbilicus doesn't come out like that. But these are just the temporary things what people are doing. If suppose this hernia persists even after 2 years of age, then we have to do a surgical repair. The tissues which have not fused beneath the umbilicus, we'll open this area. If the content is coming out, we'll put that content back and then just suture those tissues so that this area is closed nicely and the herniation does not occur. Please do remember that we are doing this operation after 2 years of age. In one of the social platforms and the mobile applications available in the market, they have mentioned that this surgery should be done after 5 years of age. But according to the standard textbook of surgery, Bailey and Love, this surgery should be done after 2 years of age. So no controversies, please. The age of operation for umbilical hernia after 2 years, right? Okay. Umbilical hernias, they are more commonly seen in blacks, 8 times more common, equal incidence in males, females, no treatment up to 2 years. After 2 years of age, we do an anatomical repair. And in umbilical hernia, we can see there is protrusion of the umbilicus forwards. Herein, I would just like to delete this line from here. Though this line is correct, but this line should have been mentioned somewhere here. There is protrusion of umbilicus in a forward direction. This story what we are reading now, this is the story of para-umbilical hernias. Para-umbilical hernia. In case of adults, especially obese patients, or maybe if the person is having cirrhotic, right, then there may be protrusion from around the umbilicus. There may be a protrusion from around the umbilicus. Maybe this side, this side, this side, or this side. Now here what you can see, beta, the umbilicus is going in. Umbilicus is not coming out. So it is not an umbilical hernia, but you are seeing a protrusion from around the umbilicus. This is what we call as para-umbilical hernias. And if there is a herniation from this side, suppose, then the umbilicus would be dipping inside. So the shape of the umbilicus becomes a C-shaped or a crescent-shaped umbilicus. Right? Okay. So para-umbilical hernias are around the umbilicus. And in para-umbilical hernias, the umbilicus becomes C-type or crescent type. And the treatment is surgery, the same anatomical repair, just the same anatomical repair, the concept what we have discussed. We can do a Mayo's operation. Right. So this is how we deal with the para-umbilical hernias. Now these images, though they belong to pediatrics beta, but just thought to include them here. This what you're seeing here is a exomphalos. Exomphalos is actually the herniation through the umbilicus. And this, what you're seeing here, beta, this is the peritoneum. So it is the peritoneum which comes out through the umbilicus, right? And there will be contents of the peritoneal cavity inside this peritoneal sac. Like what you are seeing here inside blue thing, that is actually the intestine. Plus there is a lot of fluid which is seen here, right? So there are intestinal loops seen inside. But what you can make a note of is there is a well-defined covering all around. No? This is the peritoneum, what you are seeing. And inside this peritoneum is lying the fluid and the intestines. This is exomphalos. This should be differentiated from gastroschisis. Gastroschisis is a condition where the umbilicus is absolutely normal, but there is a hole in the abdominal wall next to the umbilicus. Through that hole, the intestines are directly coming out. There is no peritoneal covering or any membrane. Intestines are directly coming out. This is called as gastroschisis. You don't see any peritoneal sac here. Umbilicus is normal, but there is a hole in the abdominal wall on the right of the umbilicus, on the right side of the umbilicus. Right. Though these problems will be discussed in pediatrics, but I thought just to give you a passing reference about this. The last in the hernias is a Spigelian hernia. Spigelian hernia is something which occurs at the level of arcuate line. Now in anatomy we'll be reading beta that in the anterior abdominal wall, if you look at the structures here from anterior to posterior, there is skin, there is superficial fascia, camper and scarpa, there is an anterior rectus sheath, then there is a rectus muscle, and then there is a posterior rectus sheath. But posterior rectus sheath is present only up to this level. Posterior rectus sheath is absent in this area. That means if you draw a line from the umbilicus to the pubic symphysis, the upper 1/3 and the lower 2/3, this is the junction. Posterior rectus sheath is not present below this junction, right? This is what we call as the arcuate line. Now, if the herniation occurs above this arcuate line through the lateral border of rectus abdominis muscle in the layers of the abdominal wall, then we call this as Spigelian hernia. Spigelian hernia. This is also called as interparietal hernia. Interparietal hernia. This is protrusion through the lateral border of rectus abdominis muscle above the arcuate line. Above the arcuate line. Also referred to as interparietal hernia. The patient presents more with pain because the neck of the sac is quite narrow, so the chances of strangulation are high, and patient often presents with pain rather than swelling. Generally, hernias present with a swelling, but here there are muscles which do not allow this bulge to be prominent. So this patient does not present with swelling, it presents with pain. Right, and the treatment is surgical repair. Okay, beta. So this is all about the different hernia stories. If we just try to summarize the different hernia stories, before we move forward, let us quickly revise the entire hernia. You can just close your eyes. Just a moment. Sorry. Right, beta. So the hernia story. Most common hernia, what we see is the inguinal hernia, and that is also indirect inguinal hernia. Most common hernia to be seen in young adults, that is indirect. Elderly, it is direct inguinal hernia. Femoral hernia is 4 times more common in females, and most common hernia to undergo strangulation is a femoral hernia. Now if we take a look, what is this inguinal hernia? Indirect, direct. We know that if the herniation occurs through the deep inguinal ring, lateral to the inferior epigastric vessels, it is indirect inguinal. If the herniation occurs through the transversalis fascia, Hesselbeck's triangle, medial to the inferior epigastric vessels, that is a direct inguinal hernia. While femoral hernia occurs through the femoral canal, landmark to distinguish indirect from direct inguinal hernia will be the inferior epigastric vessels, and landmark to distinguish inguinal from femoral hernia will be the pubic tubercle. Inguinal hernias usually present as a bulge above and medial to the pubic tubercle, while femoral hernias present as a bulge below and lateral to the pubic tubercle. If we compare the differences between indirect and direct inguinal hernia, indirect is more common in young, protrusion through the deep inguinal ring, lateral to the inferior epigastric vessels, protrusion occurs in a downward forward medial direction and extension into the scrotum is common. While direct inguinal hernias, they are less common in elderly people, protrusion through the transversalis fascia Hesselbeck's triangle, medial to the inferior epigastric vessels, protrude in a forward direction, so the chances of going into the scrotum are less. Various classifications are there for hernias. European Hernia Society, PR, primary recurrent, LMF, L lateral indirect, M medial direct inguinal, F femoral. 1, 2, 3, 1 finger, 2 finger, 3 finger. 1 finger is taken as 1.5 centimeters. NIHAS classification: 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. Clinical classification: occult, reducible, irreducible, obstructed, incarcerated. Occult, which is not visible; reducible, which is the most common. Majority of the hernias can be reduced and show a positive cuff impulse. Irreducible is because of adhesions of the hernial sac with the scrotum. Obstructed is due to narrow neck of the hernial sac, and incarcerated is due to decreased blood supply. There is gangrene, strangulation. It is an emergency type of situation. Content classification: if there is omentum coming, omentocele, epiplocele, doughy feel. Intestine, enterocele, Meckel's, litters, appendix, amnions, circumference of the intestine, richtus, W loop of bowel, Madel's. Sliding hernias: when organ forms one wall of the hernial sac, most commonly sigmoid colon, second most commonly cecum. Pantaloon, double inguinal, Cooper's, double femoral, or sometimes even inguinal and femoral is called as Cooper's. How to approach these hernia patients? Examine them in the supine position, then in a standing position. You can demonstrate the cuff impulse. You can find out which type of hernia is this. If there is any doubt, then you do a 3-finger test, which is called a Siemens test. Once the diagnosis is made, the treatment is very simple. You have to reduce the contents and apply a barrier. What we are doing is a open surgery, where we do a tension-free Prolene mesh hernioplasty or a Lichtenstein operation. In this, we can use the mesh, which may be of polypropylene, polygalactin. The mesh generally has got fine thread with large pores. Nerves which can be injured in open hernia surgery: most commonly the ilioinguinal, but even iliohypogastric and genital branch of genitofemoral can be injured. Just a quick revision of the nerves injured in the salivary glands: sublingual lingual nerve, submandibular, marginal mandibular, lingual and hypoglossal, parotid gland, facial nerve. We can also do laparoscopic surgery for hernias, the TEP and TAPP. TEP totally extraperitoneal repair and TAPP transabdominal preperitoneal repair. Femoral hernias, they are more often seen in elderly females, low weight females, and we can do various operations like Lothisen, Lockwood and McEvedy. Umbilical hernias, usually this is due to weakness in the closure of tissues beneath the umbilicus. They are common in blacks, 8 times more common in blacks with equal male-female incidence. Generally, they close spontaneously by 2 years. If not, then we do anatomical repair after 2 years of age. Paraumbilical hernias commonly seen in adults, obese, cirrhotic individuals, wherein the umbilicus dips inside as a C shape or the crescent shape and there is protrusion around the umbilicus. We have to do anatomical repairs. We can even do Mayo's operations. Then we talked something about the gastroschisis, exomphalos type of stories. Then we talked something about the Spigelian hernia. Spigelian hernia is actually protrusion through the lateral border of rectus abdominis muscle above the arcuate line through the parietes or the layers of the abdominal wall. We also call it as interparietal hernia. Generally, these patients do not present with a swelling but present with a pain. The chances of strangulation are high in Spigelian hernias because of the narrow neck of the sac. The treatment would be anatomical repair. Right, beta? Who are revise? Chaliye. Now, let's move down into the scrotum and let's take a look. What can be the problems in the scrotum, beta? Sometimes we can come across this type of situation, beta. This what you are seeing is a testicular torsion. Normal story is something like this. The spermatic cord is coming here like this. And then there is a testis. Here in beta, before we discuss about torsion, let me just give you a small glimpse. Suppose I say that this is the testis. Then around the testis, there is a tunica vaginalis. And this tunica vaginalis, beta, look at me on the screen. Yeah. The tunica vaginalis has got 2 layers. This is the visceral layer. And then there is a parietal layer. Sorry. The job of the visceral layer is to produce fluid. This is the visceral layer of tunica. This is the parietal layer of tunica. The job of the visceral layer is to produce fluid. And the job of the parietal layer, beta, God has given lymphatic channels in the parietal layer. And these lymphatic channels, they keep on absorbing the fluid so that this is producing the fluid and this is absorbing the fluid. Despite this, all the boys who are sitting here right now, all of you are having some amount of fluid in this area around your testis. And this acts as a shock absorber and prevent trauma to the testis. Right? So this is the normal story. Sometimes, beta, when this visceral layer start producing more fluid, then more fluid will get collected here and that will be called as hydrocele. If the parietal layer lymphatics suffer from traffic jam situation in filariasis, when they are not able to absorb the fluid, then also the fluid will get collected in this area, and that will also be called as hydrocele. The commonest cause of hydrocele is filariasis, when there is a traffic jam in the lymphatics of the parietal layer, right? This is the normal story. Normally, beta, what you are seeing here is that the testis is actually surrounded by this tunica on all sides. Sometimes what can happen, if this tunica is not present around the testis like this, but suppose the tunica is present around the testis something like this. There is no tunica here. That means the testis is unsupported now. And this is what we call as high investment of tunica vaginalis. The tunica is not covering the testis all around. So the testis becomes unsupported. This is something like as if the testis is hanging like a clapper in a bell. जैसे मंदिर में घंटा होता है ना, तो उस तरह से the testis is actually hanging like a clapper in a bell. Now, if this is unsupported, it can easily undergo torsion. It can easily twist. This is the commonest reason for testicular torsion. This type of deformity is called as bell clapper deformity. Bell clapper deformity. Bell clapper deformity. Testis can rotate easily. Sometimes, if this is not the reason, there is a possibility that the tunica is covering the testis all around nicely. The parietal layer is also present all around nicely. This was not nice. Right. Sometimes what happens, beta, if there is a sudden jerky movement, achanak se, sudden jerky movement. For example, suddenly there is sneezing. Generally, when a person is sneezing, there are some warning signs which come before that. So the testis come to know that there is something which is going to happen. But if suppose suddenly there is a forceful sneezing, then the testis will face that pressure and then the testis can undergo torsion, right? Or maybe if somebody is straining at stools, somebody is straining at micturition, chronic smokers, cough. If there is sudden rise in intra-abdominal pressure, that can also do this sudden movement in the testis and then the testis rotates around its axis. That is also testicular torsion. Sometimes this can occur during over-enthusiastic sexual intercourse. Sometimes this can occur during sleep also. This is simple inversion of testis. And rarely what can happen, beta? This is the spermatic cord. If suppose the spermatic cord is separated from the testis, then also the testis will become free to undergo rotation. But this is rare. So, now if we just try to understand the high investment of tunica vaginalis and let us imagine that the testis has undergone rotation, right? Now, it is not only the testis, but as you can see, the spermatic cord has also undergone rotation. So, the blood supply of the testis, that means the testicular artery which is coming from the spermatic cord, if that is twisted, if that is torted, blood supply to the testis will decrease. And then ischemia and gangrene of the testis can occur. How these patients actually present to us? There is sudden severe pain. Sudden onset of severe pain. We know whenever there is a traffic jam in the artery, if the distal part is not receiving the blood supply, then the distal part there is severe pain. And because of this ischemic insult to the testis, there may be inflammation, Reber tumor, Callet-Dollar type of story. There may be redness of the scrotum, there may be swelling of the scrotum in this area. Generally, the age group is somewhere around 10 to 20 years or maybe 10 to 25 years of age. When we examine these patients, we may find that there is some redness in the scrotum. Suppose the scrotum on examination looks to be a little red, not this red hot, but maybe mild inflammation. There is swelling of the scrotum. we get confused whether it is a case of torsion or it is just a case of inflammation of the testis and epididymis. This what you are seeing, beta, this is the epididymis. Epididymis is lying almost attached to the testis. So whenever there is infection of the testis, it is also the epididymis which is getting involved usually. So that infection of the testis and epididymis is called as epididymoorchitis. This epididymoorchitis will also present somewhat like this, redness and swelling of the scrotum. Now, if the patient comes at 2 o'clock in the night, February 23, you are the boss. You see a swelling in the scrotum. You see there is redness in the scrotum and the patient is having severe pain. This can be inflammatory, this can be torsion. What you can do is, you can just try to elevate the scrotum. If by chance, just imagine yourself that you are examining this 23, 24-year-old male with a redness swelling of the scrotum and 2 o'clock in the night. If you just elevate the scrotum beta, if it is an inflammatory problem, by giving the support, the congestion can reduce and the patient feels comfortable. And the patient may ask you, Doctor साहब, ऐसे ही रखना अपना हाथ. If the patient feels relief in pain on elevation of the scrotum, there are more chances that this is a case of epididymoorchitis. This is called as Pren's test. Pren's test is positive in epididymoorchitis. If you try to correlate with breast abscess, just a moment. Right, beta. If you just try to correlate with a breast mastitis, now in mastitis also, when there was a Staph aureus party going on inside the breast, we gave antibiotics and we gave that breast support. Because in inflammatory conditions, if you give the support, it reduces the congestion and patient feels a little relief. Here also, the same story. By elevation of the scrotum, if it is a case of testicular torsion, just by lifting the scrotum, you are not detorting the testis. It is not that the testicular artery is getting detorted and the supply to the testis is increasing. So elevation of the scrotum will not relieve pain in case of torsion of testis. Pren's sign is negative in testicular torsion. In the treatment, what we should do? 2 o'clock in the night, elevation of the scrotum, relieves pain. This should be epididymoorchitis. So you can just deal with antibiotics. But sometimes when you are elevating the scrotum and you are looking at the patient with eagerness, whether he is feeling any comfort or not, if you elevate the scrotum, you are looking at the patient and the patient is looking at you. There is no reaction. And now you are confused whether it is a case of epididymoorchitis or it is a torsion. If there is any confusion, if you are not sure that this is epididymoorchitis, take this patient in the operation theatre. Open the scrotum. See with your eyes whether it is epididymoorchitis or torsion. And the simple reason is, if you don't open the scrotum when you were confused, and if it turns out to be testicular torsion, the timing of surgery is very important. Because if it is a testicular torsion, more the duration of ischemia, more will be the risk of gangrene. If by chance, suppose next day or maybe next to next day, the patient is not getting relief and now you feel, okay, it's a testicular torsion, I think, and now I should open the scrotum. Now when you open the scrotum, you know what would have happened. It is because of your fault that you have caused gangrene to the testis. So this is something which is not acceptable. Whenever there is any doubt in the clinical judgment, better take the patient in the operation theater, open the scrotum and see with your eyes what the hell this problem is. If it turns out to be testicular torsion, and if the testes are viable, you can do the derotation of the testis and then fix the testis in the scrotum so that they do not undergo torsion again, right? This is called as derotation and orchidopexy. And for whatever reasons, if today one testis has undergone torsion, for the same reasons, maybe tomorrow the other testis can undergo torsion as well. So it is not only that you have to fix the one side affected testis, but also you have to fix the other testis to the scrotum. That means you are not only doing derotation orchidopexy here, but you also have to do orchidopexy for the other testis. That is the treatment for testicular torsion. I repeat this treatment in Hindi also. अगर मान लीजिए कभी ऐसे हालात हों कि रात को 2-3 बजे पेशेंट आया, ये रेडनेस स्वेलिंग लग रही है स्क्रोटम में, और हम प्रेंस टेस्ट करने की कोशिश कर रहे हैं, हमने उसके स्क्रोटम को हाथ लगाया और हम उसको देख रहे हैं कि उसको आराम मिल रहा है कि नहीं मिल रहा है, लेकिन मान लो उसे कुछ पता ही नहीं चल रहा है, आप उसको देख रहे हैं, वो आपको देख रहा है, और यही कहानी चलती जा रही है. दैट मीन्स यू आर नॉट श्योर कि कहानी क्या है अंदर. ऐसे में टाइम खोटी नहीं करना है. अगर अपन श्योर नहीं है, फटाक से ले चलो ऑपरेशन थिएटर में, खोल डालो इसका स्क्रोटम और अपनी आंखों से देखो कि क्या कहानी है. अगर ये एपिडिडाइमो ऑर्काइटिस हुआ तो किसी में दम नहीं कि कल को आपसे उंगली उठाएगा, क्योंकि आपने टॉर्जन सोच के इसको खोला था. कोई बात नहीं, निकल गई एपिडिडाइमो ऑर्काइटिस, एंटीबायोटिक देके ठीक कर देंगे. लेकिन अगर ये टॉर्जन का केस था और आपने इसका स्क्रोटम नहीं खोला तो कल इसको गैंग्रीन हो जाएगा टेस्टिस में, और उसके बाद कोई आपको छोड़ेगा नहीं, क्योंकि आपकी गलती की वजह से उसके टेस्टिस में गैंग्रीन हुआ. इसलिए ऐसे हालात में जब भी कोई डाउट है या अगर टॉर्जन का डायग्नोसिस आपको लग रहा है तो आप इसका स्क्रोटम खोलिए. अगर टेस्टिस जिंदा है तो इस टेस्टिस को डीरोटेट करिए. डीरोटेट करने के बाद टेस्टिस को स्क्रोटम में फिक्स करिए, मतलब ऑर्किडोपेक्सी करिए. और जिन कारणों से आज इस टेस्टिस के साथ ऐसा हादसा हुआ है, उन्हीं कारणों से कल को दूसरी के साथ भी ऐसा हो सकता है. इसलिए दूसरी को भी बचाना जरूरी होता है. इसी ऑपरेशन में पहली को भी फिक्स करेंगे और दूसरी जो नॉर्मल है उसको भी फिक्स करेंगे. इसको बोलते हैं डीरोटेशन ऑर्किडोपेक्सी विथ कॉन्ट्रालैटरल ऑर्किडोपेक्सी. कभी कभी ऐसा होता है, when you open the scrotum suppose and you find that this testis is not viable. If this is gangrene, treatment of gangrene we know is amputation. That means we have to remove this gangrenous testis. Orchidectomy has to be done. So if by chance you find that the testis is gangrenous, you have to do an orchidectomy, but please do not forget to fix the other testis at the same setting. Do a contralateral orchidopexy. Right? I hope you got the concept of testicular torsion nicely. Most common cause of testicular torsion is a Bell-Clapper deformity. Now this has been a recently asked question. Bell-Clapper deformity. This is due to high investment of tunica vaginalis. Apart from this, there can be simple inversion of testis, sudden rise in intra-abdominal pressure, or maybe due to separation of the spermatic cord. Most commonly seen during 10 to 20 years of age. There is sudden severe pain, swelling, redness in the scrotum. A clinical test to distinguish from epididymo orchitis is a Prince test. Prince test is positive in epididymo orchitis, while it is negative in testicular torsion. Elevation of the scrotum relief pain in epididymo orchitis. This is what is a Prenz test. Elevation of the scrotum relief pain in epididymal orchitis. That is what is a Prenz test. Best thing to be done in these situations is immediate scrotal exploration. If the testes are viable, which are usually if you operate before 12 to 24 hours, then we do a derotation. Orchidopexy, and simultaneously we do a contralateral orchidopexy. Contralateral orchidopexy. If the testes are not viable, patient coming to you after 12 to 24 hours, there is no point in doing a derotation or something. Better to do a orchidectomy, remove the affected testis, and please do not forget to do a contralateral orchidopexy. Another pathology in the scrotum is varicocele. This was an image-based question on 4th of June 2022. This is simply abnormal dilatation of the pampiniform plexus of veins around the testis. If we just try to revisit our knowledge, I hope no. Okay. So here in beta, what do you expect? What are these two things, beta? ये क्या बना होगा? Kidneys. Right. Very good. You know, the inferior vena cava is located slightly to the right. Because of this reason, the right renal vein is short and the left renal vein is long. The right testicular vein opens directly into the inferior vena cava, but the left testicular vein opens in the left renal vein. If you just try to carefully take a look better, the IVC is situated slightly onto the right. The right renal vein is short, the left renal vein is long. Right testicular vein opens directly into the IVC. The left testicular vein opens into the left renal vein. And if you can see this angle better, this is a 90-degree angle. You know that veins have got valves. So here also there would be valves. And the job of this valve is that whatever blood is moving up, that does not fall back. Now just imagine blood flow in this renal vein is moving like this, right? This is the horizontal flow of blood. I repeat, you can see the blood in the left renal vein is moving like this. This is the horizontal flow of blood. And blood in the testicular vein is moving like this. This is the vertical flow of blood, right? You can understand better, because of the horizontal flow of blood in the left renal vein, there will be resistance. And because of this resistance, there will be some back pressure. And this back pressure can destroy these valves. And if these valves are destroyed, then you can understand the blood will not be able to move up easily. The blood will be falling down, 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 down. And because of this reason, what can happen? There may be pooling of blood in the spermatic veins and the pampiniform plexus of veins around the testis. And because of this, these veins will become abnormally dilated and tortuous. And this abnormal dilated tortuous veins around the testis is what we call as varicocele. Right, so abnormal dilatation of pampiniform plexus of veins is varicocele. This condition is commonly seen in tall males, especially who live in hot climate, because they have got a pendulous scrotum. The distance to be traveled is more. And the reason what we can understand is there is incompetence of these valves due to high pressure. And this is because of the anatomical arrangement. Now, if we try to understand what will be the problem, if this is the situation, if the veins in the scrotum are abnormally dilated, varicose, right, there will be pooling of blood in these veins. Blood is hot, and pooling of blood in the scrotum will increase the temperature of the scrotum. We all know that God has thrown the testis out of the abdomen in males because intra-abdominal temperature is 2 degrees centigrade higher. So the testes are thrown out into the scrotum where the temperature is lower and the spermatogenesis can be good. But in case of varicocele, if the temperature of the scrotum increases, then it will definitely interfere with spermatogenesis and the patient may not be having babies. Patient may be sterile. Apart from this, when we clinically examine these varicocele patients, these dilated veins in the scrotum, they appear as bag of worms, as if there are earthworms in the scrotum. केचुए जैसी फील आती है, जैसे स्क्रोटम में केचुए हैं, earthworms हैं. This is bag of worm feel, and this was given in the question on 4th of June. This was the image, plus there was a bag of worm feeling given, and they asked what is the diagnosis. So this was a clear-cut case of varicocele. Now, how we should proceed in the management of these varicoceles? Basically, the patient is having these dilated veins. If suppose the temperature is interfering with spermatogenesis, now this is a serious issue. What we can do here is, समस्या क्या है इसमें? स्क्रोटम में टेम्परेचर बढ़ गया है, गर्मी हो गई स्क्रोटम में, एसी लगाना पड़ेगा. So you have to actually put an air conditioner in the scrotum. That means you don't want pooling of blood in the scrotum. To destroy these dilated veins, we have got a wonderful option of doing a sclerotherapy. So you can inject a sclerosing agent and sclerose these dilated veins. So now these veins will be destroyed and there won't be any pooling. The temperature will drop, spermatogenesis will start, and the patient will have kids. Right? Or you can do surgery where you can ligate these dilated veins. Varicocelectomy can be done. Alternative route of venous drainage from the testis after we ligate these veins is the cremasteric vein. There would be diversion through the cremasteric vein for the venous drainage from the testis. Right, beta. So varicocele is the abnormal dilatation of pampiniform plexus of veins around the testis. The story is due to valvular incompetence in the left testicular vein due to high pressure. There is a vague dragging sensation in the scrotum, sterility, and the MCQ on 4th of June. Bag of worm feel. Bag of worm feel. We can do sclerotherapy, varicocelectomy, and alternative route for venous drainage after we destroy these veins is the cremasteric vein. Cremasteric vein. Or you would have written it here, right. The last of the surgical abnormalities in the scrotum is hydrocele. And hydrocele we have just now seen. It is simply abnormal collection of fluid within the processus vaginalis. Most common cause of hydrocele is filariasis, and this filariasis is prevalent in eastern UP and Bihar in India. Eastern UP and Bihar. Depending on what is the site of collection of fluid, we can classify these hydroceles into different types. Just look at these images, beta. If suppose there is fluid collection confined within the scrotum, which is the most common type, this is called as a vaginal hydrocele. Vaginal. If the fluid extends from the scrotum into the inguinal canal, then we call it as infantile. And the congenital or communicating hydrocele beta, we just now saw in the congenital hernia and hydrocele story, that if the communication of the peritoneum, that is processus vaginalis, remains patent even after birth, then whatever is there inside the peritoneal cavity, that can come through this connection into the scrotum. If fluid comes into the scrotum, we call it as congenital hydrocele, also called as a communicating hydrocele, as it is communicating with the peritoneal cavity, right? Okay, sometimes we can find collection of fluid like this. This is the testis, this is the testis. There is no fluid collection seen around the testis here, but sometimes this would be the spermatic cord. If there is abnormal fluid collection somewhere in the spermatic cord, this is called as encysted hydrocele of the spermatic cord. There is no collection of fluid around the testis, but there is abnormal collection of fluid somewhere in relation to spermatic cord. This is encysted hydrocele of the cord. Sometimes it is not the fluid. Sometimes the sperms get collected like this. If the sperms get collected somewhere in relation to the spermatic cord beta, that is called as spermatocele. थोड़ा ज़्यादा हो गया है. This is called as a spermatocele, right? So spermatocele will also present as a swelling in relation to the spermatic cord away from the testis. Okay, so there are two pathologies beta. One is hydrocele, what we are talking about, and another not hydrocele but just a spermatocele, collection of sperms in relation to spermatic cord. Whatever it is, whether it is encysted hydrocele of the cord or it is spermatocele, when you examine these patients, you feel there is one testis, second testis, and God has given third testis also. So a three testicle feeling, a three testicle appearance can be seen in encysted hydrocele of the cord and spermatocele, right? Okay, G. In females also we can find this hydrocele when fluid gets collected within the inguinal canal. So here we are just trying to discuss about the different types of hydrocele, vaginal being the most common, infantile, congenital, encysted hydrocele of the spermatic cord. This gives us a three testicle appearance. Three testicle appearance. This three testicle appearance is also seen in spermatocele, and this was a recently asked question, not in the last exam but before that. Three testicle appearance is seen in, and the answer there was spermatocele. A hydrocele in females is hydrocele of canal of Nuck, that is when fluid is present within the inguinal canal. Since most common type of hydrocele is something like this, where there is fluid collection confined within the scrotum, so most commonly the patients will present with a scrotal swelling, and whenever there is a clear fluid inside any swelling in the body, if we try to throw the light from one side, we can see the transillumination from the other side. The brilliantly transilluminant swelling in the body is a cystic hygroma. Again, there is a clear lymph inside that. Ranula, meningocele, hydrocele, and sometimes branchial cyst can show positive transillumination. Just imagine February 23, 25-year-old patient comes to you in your OPD with a scrotal enlargement. The commonest reason for scrotal enlargement is hydrocele. When you examine these patients, what you can do is, You can see that scrotal enlargement, and now you have to switch off the lights in the OPD. When you switch off the lights, and if you try to use a torch and try to throw the light from one side, if there is clear fluid inside, you will see the light getting transmitted on the other side. That is a positive trans illumination. For example, if we just try to take a look, we have switched off the lights, and now what we are trying to do is we are just trying to throw the light from one side of the swelling. And herein, if there is clear fluid inside, you will see the light getting transmitted, positive trans illumination. Another picture somewhat like this. This is how you can see a positive trans illumination if there is clear fluid inside. Many times, beta, we might come across a situation where we are trying to throw the light, but we are not able to see the trans illumination. We are not able to see the light getting transmitted. Many times the real situation is you just try to do something like this with the torch, that probably the cells are weak. What is the reason why the light is not coming? And many times, you get tempted. If you're not seeing the trans illumination, but you feel that it is a hydrocele, you might be tempted to put a needle into this. Now, if you put a needle into this and aspirate, if clear fluid comes out, it means hydrocele. So your diagnosis is clear, but never do that. Because if the trans illumination is negative and the scrotum is enlarged, this might be a case of a solid tumor in the testis. This might be a case of testicular cancer. Most common cancer in a young male is a testicular cancer. If you put a needle and a testicular cancer, when you are withdrawing the needle, there is a risk of spillage of cancer cells into the scrotum. Before putting the needle, the cancer would have confined within the testis. But when you are withdrawing the needle, you might spill the cancer all over the scrotum. So transscrotal aphaneses are never done. Never put a needle into this, right? Because if it turns out to be tumor, it might be a big problem for the patient, right? Whenever there is any doubt whether it is hydrocele or something else, then you can simply get an ultrasound done, and we know ultrasound is a wonderful investigation for fluid. So most commonly, these patients of hydrocele present with scrotal swelling, trans illumination is positive. If in doubt, do an ultrasound of the scrotum. Transscrotal aphanasy, fine needle aspiration, is contraindicated. Never do that. Howsoever tempted you are, you might be feeling that there is nobody in the OPD, you are all alone, lights are off, who will come to know? But never do that, right? Transscrotal aphanesis is absolutely contraindicated. These are the images of hydrocele, what we can see. The scrotal enlargement. In the treatment for these hydroceles, what we can do, now beta, this would be the surgery which you would be doing in February 23. This can be done under local anesthesia also. If you look at the reason why hydrocele has occurred, it is because of the traffic jam of the lymphatics in the parietal layer. So what you are doing here is, just imagine that you are doing this operation. You make a longitudinal incision on the scrotum, cut the skin and the facial layers of the scrotum. With the other hand, you are giving the pressure from below so that this swelling is becoming prominent above. And that is how you are able to see this swelling above. Now, what you have to do is, all this what you are seeing inside, beta, this is fluid inside, right? you have to make an incision here, and you have to ask the assistant to be absolutely ready. As soon as you make an incision in this layer, the fluid will gush out, and you ask the assistant to suck out all the fluid. Suck out with a suction catheter, right? With a suction catheter. The assistant has to use a suction catheter. As soon as you cut this, the assistant sucks out all the fluid with a suction catheter, and then all the fluid is gone. You extend the incision like this. Now you invert this flap on this side, that flap on that side. Suppose this is the parietal layer, what we are seeing all around. You have made a longitudinal cut here, so there are two flaps. Now you just invert this flap on this side, invert this flap on this side. That means you have removed the parietal layer from in front of the testis, and you just suture it behind the testis. So now the visceral layer has been exposed directly to the scrotum. Parietal layer, which was having the traffic jam in the lymphatics, which was not able to absorb the fluid, you have just removed that parietal layer from the testis. The visceral layer has been exposed now to the scrotum. Whatever fluid will be produced, that will be absorbed not by the parietal layer, but by the lymphatics present in the scrotal fascia. This is called as eversion of sac. This is called as eversion of sac or Jaboulet's operation. So treatment of choice for hydrocele is eversion of sac. This is called as Jaboulet's operation. Another operation which we can do here is a Lord's operation. Another operation what can be done is a Lord's operation. This is plication of thin-walled sac in small to medium-sized hydroceles. Plication of thin-walled sac in small to medium-sized hydroceles. The treatment of choice for hydrocele is eversion of sac or Jaboulet's operation. Now, beta, treatment of choice for congenital hydrocele. Congenital hydrocele. Yes, very good. The treatment for congenital hydrocele is herniatomy. And beta, what is the age for doing herniatomy in congenital hydrocele or congenital hernia? Very good. After 3 years. That is how we are managing these hydroceles. If we move from the scrotum to the penile area, there are very small pathologies in the penis. Phimosis, paraphimosis. Phimosis is something like this. Herein you can see beta that how the prepuce is the foreskin over the glans beta. जो glans penis होता है ना, उसके ऊपर की जो skin है, उसको अपन prepuce बोलते हैं. Now, sometimes this prepuce may be tight. If you are not able to take the prepuce over the glans, this is phimosis. This is considered physiological in small babies. Again, if I take you to the slum areas, and if we were talking about those small babies without clothes, they are moving here and there, then many times you will find that small babies, 2-3 years old babies, they are just walking here and there without the clothes, and the prepuce is actually hanging down. That is something which is physiological, that is not pathological. So we do not consider phimosis pathological up to 3 years of age. Earlier it was 6 years, but now it is 3 years. However, if the story persists even after 3 years of age, then we call it as pathological, and this will require treatment. Now, what can be the problem in this phimosis baby beta? What is the problem? Why we want to do the treatment for this? We can understand if this prepuce is too tight, then the secretions which are taking place at the coronal sulcus, here beta, here is the coronal sulcus inside, and there are glands which are present here. These glands, they are doing some secretions, and those secretions are coming in this area. If this prepuce is too tight, these secretions will remain inside like this. They will cause chronic irritation, and this chronic irritation can even lead to cancer of penis. Those individuals who do not clean their glands on a regular basis, those who do not maintain a proper hygiene of this area, the smegma and the secretions remain trapped in this area, can lead to chronic irritation and penile cancer. The commonest cause of penile cancer is poor hygiene. It is because of this reason, beta, if the baby is more than 3 years of age, then it is highly recommended that we should do a circumcision. In circumcision, beta, what we are actually doing is very small operation, which is a customary operation in Jews and Muslims. We just remove the foreskin. We do a small operation where what we are doing is something like this. We just cut the foreskin, and this skin is sutured here. So you can see the glands, and the skin is sutured at the coronal sulcus. Now there is no risk that secretions from the coronal sulcus will be trapped here, right? So the chances of cancer will not be there. It is said, beta, that if we do a circumcision before 28 days of life, बच्चे के पैदा होने के अगर 28 दिन के अंदर सर्कमसीजन कर दिया जाए तो इसमें कैंसर कभी नहीं होता. Who knows, probably this might be the reason why why circumcision is customary in Jews and Muslims. Right, beta. There is another condition called as paraphimosis. Paraphimosis is something, beta, wherein the prepuce which is present here, suppose by chance that was retracted for some or the other reason, and now we cannot bring this retracted prepuce back onto the glans. That is paraphimosis. In phimosis, we are not able to take the prepuce back onto the glans. In paraphimosis, whatever prepuce has gone back, if we are not able to bring that prepuce onto the glans, that is paraphimosis. Now, what can happen in these situations? Sometimes this skin here can form a ring, and if this ring becomes too tight, it can press the blood vessels which are supplying blood to the glands. And just imagine, if the ring puts pressure on the blood vessels and there is no supply to the glands, there will be gangrene of the glands and treatment for gangrene. Oh, amputation. If there is a gangrene, yes, we don't want that. So we have to bring this retracted prepuce back onto the glans. We can use some ice bags, compression to reduce the swelling and try to do a manual reduction of this prepuce. Sometimes we can make a slit, a cut on the ring, so the ring opens up, and then we can bring this prepuce back. A dorsal slit operation, or sometimes we have to do a circumcision, that means excise the skin. This is what we do in the treatment of phimosis and paraphimosis. Let's take a look what all is written there. So herein, if we take a look at these pictures also, beta, we can see this is a phimosis. The prepuce is not easily retractable onto the glans. The prepuce is a little tight in this area. This is a diagram explanation. Inability to retract the prepuce. When this is not possible, this is phimosis. Inability to bring back the retracted prepuce onto the glans, that is paraphimosis. Right. This phimosis is considered physiological up to 3 years of age. No treatment is required for physiological phimosis, but we know in phimosis there is a risk of poor hygiene which can cause penile cancer. So the treatment has to be done for pathological phimosis. Circumcision. Most commonly, circumcision is done for religious reasons. Most commonly, this is done in Jews and Muslims. Paraphimosis, we have to do manual reduction of prepuce to reduce the swelling. We can use ice bags, compressions to reduce the swelling. Ice bags, compressions to reduce the swelling. If required, we can do a dorsal slit operation. If required, we can even do circumcision. But generally, this is sufficient. Manual reduction of prepuce. These are the different options in the treatment of paraphimosis. Then there is a condition called as Peyronie's disease. Now, Peyronie's disease, beta, if we take a look at the structure of penis, there is a corpora cavernosa. There are two corpora cavernosa in the penile shaft. In the center, we know there is a corpora spongiosa. The glans is made only of spongiosa. That is why glans is a spongy tissue. There is no cavernosa in the glans. Just imagine a cricket match. If by chance the batsman is not using the guard around the penis and a fast bowler hits a cricket ball right onto his penis, you can imagine because of that injury there will be inflammation, and inflammation will cause healing by fibrosis, and there is a possibility that a hard fibrous plaque may develop in the corpora cavernosa. It may form in one cavernosa, it may form in both the cavernosas. If it forms in one cavernosa, generally what will happen? In a flaccid penis, no problems to the patient. But when the patient will have erection of penis, then because of this hard fibrous plaque, there is a possibility that at the time of erection, the penis will bend down towards the site of plaque. And now this will be painful as well. At the time of erection, the penis is bending. If the person is playing, if the batsman is batting, then usually it is the dorsal cavernosa which is getting affected. That means dorsal cavernosa is here. So if there is a plaque in this cavernosa, at the time of erection, the penis is bending upwards, something like this. And this curvature of the penis is called as chordae, something like this. This is the dorsal chordae, what you will see in Peyronie's disease. Now, what we have seen over a period of time, that usually whatever this fibrous plaque has formed, due to healing mechanisms in the body, there is a possibility that maybe in 1 year, 2 years or 3 years time, this plaque will automatically be resolved by the scavenging mechanisms in the body, and the person will become normal. So initially when the patient comes to us, we keep on counseling the patient, we keep on reassuring the patient. Suppose a 30-year-old gentleman comes to you with Peyronie's disease and you're just counseling him. कोई बात नहीं, घबराओ नहीं, ठीक हो जाएगा. He is listening to your advice, he is waiting for that healing. 6 months, 1 year, 1.5 years, 2 years, he's continuously coming, doctor, do something. My life is passing. So, now in these cases, what we can do, if we try to do a surgery, make an incision in this area and remove the plaque, again we are creating a raw area here. Again there will be healing by fibrosis and maybe a bigger plaque will form. Oh, so simple surgical removal will not be the answer. People thought a lot about it. There was a person called as Nesbitt. He said, oh, so what is the problem? At the time of erection, because of this, the penis is bending up. We cannot remove the plaque. Okay, we can do one thing. We can create another plaque. We can create another plaque in the opposite cavernosa. If we can create another plaque in the opposite cavernosa, then what will happen? Because of this new plaque, the penis will bend like this and the resultant will be somewhat like this. That means, now should we ask the same bowler to hit the ball on the opposite side? Jokes apart, but this is what we actually do if the patients are not getting relief by just reassurance. We do a Nesbitt operation. We don't marrow the cricket ball, we don't throw the cricket ball, but we just put some suture in the opposite cavernosa so that it acts as a plaque, right? This is what is Peyronie's disease, my dear friends. There's a hard fibrous plaque which is forming in one or both corpora cavernosa. Actually, it is the covering of the cavernosa, one or both tunica of corpora cavernosa. This story is associated with trauma. It can also be associated with another condition, which is a Dupuytren's contracture, wherein the patient develops a disease where fibrous tissue forms here and there in the body. The problem is not of a flaccid penis, it is the erect penis which bends towards the plaque side. Spontaneous resolution can occur. We just need to reassure. We have even tried those Baba waves, the shock waves in the treatment of these plaques. But if it persists, then we do a Nesbitt's operation. Nesbitt's operation. This is placing a non-absorbable suture in the opposite cavernosa. Placing a non-absorbable suture in the opposite cavernosa. That is how we can solve the erection problem. Fracture penis. Oh my God, is this also some entity? Penile fracture. Yes, sometimes due to over-enthusiastic sexual intercourse, there might be rupture of the tunica of the corpora cavernosa. That is what we call as fracture penis. Rupture of the tunica of corpora cavernosa, maybe over-enthusiastic sexual intercourse, or maybe due to some trauma type of story. The treatment is very simple. We have to just repair the tunica. Another problem is erectile dysfunction. Now, erectile dysfunction, we all can understand better. We all have seen so many advertisements regarding this. If you switch on the television at 12 o'clock in the night, there are so many advertisements coming, some medicine or something like that. And I hope, beta, you remember when we are moving in the trains in India, then whenever the station is approaching, the railway station is approaching, then you will see the walls painted all over, right? With the advertisements. There would be a phone number written out there. So, now what is actually this? Erectile dysfunction is simply failure to achieve or maintain erection. Now, what can be the causes for these erectile dysfunctions? Most commonly, it is actually ischemic, especially diabetes. So, why the penis does not erect? Most commonly, it is the ischemic cause, like associated with diabetes, or maybe hypertension, dyslipidemia, psychogenic, maybe due to stress, anxiety, and all that stuff. The patient may not be able to achieve or maintain the erection. What should we do in the treatment? Ideally, we should treat the cause. Whatever is the cause, if it is diabetes or something, hypertension, then we have to treat the cause. We have to counsel the patient. Apart from this, we can give some medicines. We all know, beta, that why erection actually occurs. That is because of pooling of blood in the corpora cavernosa. There are blood vessels in the corpora cavernosa. When the blood vessels pool with the blood, then there is erection, right? So we can give some medicines which can increase the pooling of blood in the cavernosa. Like we all know the tablets for erection like Viagra, right? Sildenafil. These type of tablets can be used. Sildenafil. If by chance, even these medicines, sometimes the patients are over enthusiastic and they keep on taking these tablets, and a day will come when these tablets are also not working. In those patients, we can even put some penile implants. Now, these penile implants are put in the corpora cavernosa, and these penile implants are something like this, beta. Suppose you are putting a penile implant in the cavernosa. This implant is actually having a balloon type of thing. Suppose I put an implant like this. This has got a balloon type of thing. When you press the button, the balloon is going to inflate. And if the balloon inflates, then the erection will occur. So it depends on the patient when he wants to have erection and when he does not want to have erection. Right? Just by pressing the button, the balloon will be inflated and he will have that erection. And the last thing in the penile pathologies is priapism. Priapism is actually persistent, painful pathological erection of penis. If by chance the penis remains erect for more than 4 hours, 4 घंटे से ज़्यादा, not physiological, pathological. If the penis remains erect for more than 4 hours like this, that means there has to be some persistent pooling of blood in the corpora cavernosa. Most commonly, it is classified as low flow. Actually, there are two types, beta, low flow priapism and a high flow priapism. Most common is the low flow priapism, what we commonly see. In this low flow priapism, the ischemic priapism, most common cause is idiopathic. However, psychogenic, any hypercoagulable states, overuse of sildenafil. Suppose the requirement of Viagra was of 1 tablet, but somebody takes 10 tablets. Then this might cause pooling of blood in the cava nosa for a long period of time, because of which this penis remains erect for a longer period, more than 4 hours. Hypercoagulable states, that is slowing of circulation, would be there. So the blood pooling in the cava nosa can occur. Sickle cell anemias. We know in sickle cell anemia, the RBCs are of sickle shape. So when the RBC go inside the cava nosa, they remain trapped inside the cava nosa. They are not able to come out easily. So this can also cause pooling of blood in the cava nosa. In this low flow type of priapism, it is a deoxygenated blood which is there in the cava nosa. So when we test for the penile blood, it is actually a venous blood. And we all know, if we compare the venous blood from arterial blood, the oxygen level will be low and the CO2 levels will be more. So when we do the testing of blood in priapism, we usually find a venous blood. In the treatment, what we are supposed to do, beta, the problem here is, if the penis remains erect like this for more than 4 hours, there is a risk of damage to the nerves. And if the nerves get permanently damaged, then patient will not be able to have erection ever in his life. So in order to avoid that permanent damage, we can put the IV cannulas as soon as the patient comes to us. We can simply take the IV cannula, put a IV cannula here, put a IV cannula here, and just aspirate the blood from the cava nosa. Simple aspiration of blood from the cava nosa will cause flaccidity of the penis, and the chances of impotency will not be there. So, in the treatment for these priapisms, we are simply doing aspiration of blood from the cava nosa. If required, if aspiration does not help, then we can divert the blood from cava nosa into some or the other veins. That is, a shunt can be created to divert the blood from the cava nosa. Shunt surgery can be done. A high flow priapism is something which is rare. That is because of trauma. Sometimes, if suppose there is a trauma because of which the artery has ruptured, then obviously there will be oxygenated blood. So in this oxygenated blood, there will be high oxygen and less CO2. This is something which is rare. And if there is a leak from the vessel, agar bleeding ho rahi hai beta, arterial bleed hai, so we all understand what we can do in the management of arterial bleeds. If there is a leak from this area, then we can take that Fogarty catheter and put some substance here which can seal the leak. A coil can be placed here, that is angioembolization. Right? So this is what we do for high flow priapisms. Right? This is all about the penile story, and we are almost done with the adult surgical problems. We are still left with 5 more pages, I guess. So what we'll do is, tomorrow morning when we start the session at 9 o'clock, first we'll be completing this rectum and anal canal story. And since we've exceeded the stipulated time, I would just like to say thank you to all of you, beta, and just like to remind you about certain things that 17th of December, you know the entire game, beta. You know what is going to be asked on 17th of December. The content, what we are trying to understand, the knowledge, what we are trying to gain, the concepts, what we are trying to make. These concepts are going to be the real game changer on 17th of December. The language of the question, the language of the option may not be the same what we are discussing, but the concepts are going to be the same. If you are writing those concepts, if you're writing those examples in the workbooks along with the notes on a daily basis, then when you will be revising these things in the month of November, you will also be revising these concepts. that will help you more on 17th of December. We know, beta, that this journey is not an easy journey, but we also know that this is not something which is impossible or not doable. And we know our seniors, they have been doing this time and again. We also have to follow the same path. We have to take care of the NBE also. So for us, we know the passing marks are not 150. We take that as 180. And let us fight for that 180. What the hell? What is the problem there? Let us try to remember these concepts nicely. Let us keep working hard on a daily basis. Because whatever lessons we are discussing on a daily basis, after the classes, take half an hour, 1 hour rest. Go to the workbook again. And if there is anything where you feel that you are lacking somewhere, just quickly go back to the video. This is the biggest advantage of the online live classes. You can go back to that video, you can revisit the video, and you can quickly recall, oh, this story was because of this. And you can just make a note right there, right? If we are able to do this, which is very much doable on a daily basis, make a strict discipline, make a strict schedule. Gradually, every Tuesday, we will realize that yes, we are taking a step forward. We are taking a step forward. Believe me, my dear friends, it is not that somebody is doing hard work for just 10 days and he will get the rewards nicely. No. We all are doctors. We are in the most noble profession of this country. We know it requires a lot of dedication, discipline, hard work, positivity, respect, gratitude, everything. And we all have that. No one of us is having any negative thought inside us. Let us stick to that positivity inside. Let us maintain that strict disciplinary schedule on a daily basis. Let us keep grinding on a daily basis. And let us just remind ourselves of all the sacrifices which we have made in those last 6 years. And also, please remind the sacrifices what our parents have made for us in those last 6 years. Let nobody on this earth come in between your dreams. Keep fighting as hard as possible on a daily basis. These small steps taken on a daily basis will really prove big in the end. And this is what is going to help. I'm confident, I'm pretty sure that since you are watching these classes like anything, it is only your dedication. It is only the fire inside your belly which is pumping you hard. And that is why you are stuck. You are fighting it. Keep on doing this, beta. God is watching you. And He will bless you with great results. You will come out with flying colors. God bless you all. Wish you good night. Take care. Bye-bye. Please do WhatsApp for any queries. I'll respond to you before 9 o'clock tomorrow morning. God bless.